Hello and welcome to another series of OncoPearls. I am Dr. Raza and today I am going to discuss about ductal carcinoma in situ of the breast. So to begin with, we just discussed that what is ductal carcinoma in situ or DCIS. It is a neoplastic proliferation of epithelial cells in the ductal and lobular system of the mammary glands that can present with marked or subtle atypia. There is around 15 to 50% of risk of progression to invasive cancer if it is left intact. The hormone receptor or estrogen receptor testing is recommended in all the cases of DCIS because it impacts further treatment. DCIS is usually staged as TIS or stage 0 disease in the breast cancer because it is a carcinoma in situ only. It can be associated with less than or equal to 1 millimeter of invasive breast cancer as well. It mostly presents without any clinical findings where it is detected during screening in around 80 to 85% of the cases. However, it can rarely present with a mass or a nipple discharge. Calcifications are the most important findings in the imaging mammography that is usually being done during the screening process. In pathological examination, we usually see the nuclear grade that can be low, intermediate, or high, whether there is any presence of necrosis or not, and how is the architectural pattern of the disease. Moreover, size and extent of the lesion is also studied. So these are the different pathological factors that define DCIS and its further management and prognosis. The primary goal of the treatment is to prevent local recurrence because around half of the cases of DCIS, if left untreated, they recur with an invasive breast cancer. Surgical treatment is the mainstay, where mastectomy is done that reduces the risk of local recurrence to 1 to 2% only. Moreover, breast conserving therapy consisting of lumpectomy and radiation therapy has also promising results. The recommendations for clear margins is around 2 millimeters. For the management of DCIS with breast conserving therapy, axillary lymph node dissection or sentinel lymph node biopsy is not recommended usually. However, it can be considered in patients with higher risk of invasive cancer and those who are undergoing mastectomy because mastectomy can lead to architectural distortion and disruption of the lymph nodes. Numerous studies are ongoing that show surveillance can be carried out for the low risk diseases. Radiation therapy plays a vital role and has around 30 to 60% benefit in the local outcomes. Two types of radiation therapies can be considered, that is conventional spread over 5 to 6 weeks or hypofractionated that is spread over 3 to 4 weeks. There is no survival benefit as per the studies with the help of radiation therapy. Margins less than 2 mm after lumpectomy, large tumor size, young patient, a high nuclear grade, and presence of necrosis increase the risk of local recurrence. As already discussed, that we test for estrogen receptor status in all the patients with DCIS, so there is a main role of endocrine therapy as well. Adjuvant tamoxifen 20 milligrams per day is usually recommended for 5 years to prevent local recurrence and contralateral disease as well. It is supported by two studies. The first one is NSABP B24 that was carried out in both the pre and postmenopausal women with estrogen receptor positive disease, and it showed 32% relative reduction in the risk of local recurrence and 53% relative reduction in contralateral disease over a period of 15 years. The study failed to show any overall survival benefit with the use of adjuvant tamoxifen. The second study was NSABP-B35 that was primarily carried out in the postmenopausal women, in which anastrozole was compared with tamoxifen, that showed breast cancer free interval with anastrozole was 93.5% and with tamoxifen was around 89% over a period of 10 years. So this was the brief introduction and the management strategies for ductal carcinoma in situ. If you have any comments or suggestions, you can always enter them in your comments section and box. Thank you very much for your patient listening.